So today we start our discussion on infections. So if I tell you that history here is fever and cough, here's a chest radiograph, what do we see?
There's a consolidation in the left lung base.
Where is it on the lateral?
On the lateral, this is more anterior.
Yeah, so it's over here overlying the heart, so
Yeah.
where would that be then? That would be in the, well, this part of the lung is the lingula.
Right.
Right, so this patient has pneumonia in the lingula. What's the most likely cause in your regular outpatient? This would be what?
Probably bacterial pneumonia.
Bacterial pneumonia, usually caused by?
Strep pneumonia.
Yeah, usually caused by strep pneumonia. So that's the most common community-acquired bacterial pneumonia. So lobar consolidation is classic. Here you have a classic right middle lobe consolidation. So what happens is the bacteria are inhaled within the lobe, and the exudate spreads out within that lobe. So rather than spreading through the bronchial tree, so you get a confluent consolidation confined to a lobe. So that's what we see with lobar pneumonia. So if I tell you this is pneumonia, what's unusual about this case? Armand, anything unusual about this case if I tell you it's pneumonia?
It looks sort of like an expansile.
Yeah, exactly right. So what is bulging here?
The major fissure.
Yeah, the major fissure is bulging. So this is pneumonia with increased volume because of the extensive consolidation. Of course, mass is also the differential, but I'll tell you it's pneumonia. So what kind of pneumonia, what do we call this?
Friedlanders.
Friedlanders, and the typical organism is?
Klebsiella.
Klebsiella, right. So Klebsiella pneumonia, gram-negative, voluminous inflammatory consolidation. Of course, you can have complications, cavities, abscesses, and pyema. Right? What's different here about if I tell you this is pneumonia, what's different about this? It's multifocal, right? It's kind of patchy, bilateral. So what do we call this? We call this bronchopneumonia. And here the organism is typically staph, right? So staph pneumonia, usually secondary to aspiration. That's the classic organism for bronchopneumonia. The other term for this is lobular pneumonia, so don't confuse that with lobar pneumonia, right? So lobular pneumonia and lobar pneumonia are two different things. This spreads via the airways. So that's why it's multifocal. It spreads all over the lung via the airways. You can get these patchy consolidations. So that's bronchopneumonia. Right. By the way, having said that, it doesn't mean that all bronchopneumonias or staph only gives bronchopneumonia and strep only gives lobar pneumonia. Either one can do either, right? This is just the typical classic appearances of these. What do we have here? What's unusual about this appearance here in this case?
Predominant reticular opacities.
Yeah, so here it's mostly reticular opacities, right? So what does that suggest? An atypical pneumonia, right? So what could this be? So mycoplasma is your classic organism for atypical pneumonia. Is there anything else that gives you atypical pneumonia? Viral pneumonia? Anything else?
Chlamydia.
Okay. Anything else? In Newark? This patient is HIV positive, pneumocystis. Right. So around here we also consider pneumocystis. So atypical pneumonias, pneumocystis, viral mycoplasma, and these can give you an interstitial pattern, at least in the beginning, and then they can go on as they get worse, then you can develop alveolar consolidations. Mycoplasma pneumonia, the classic, most common non-bacterial pneumonia, the interstitial pattern, reticular opacities or reticular nodular opacities, more reticular, I guess. Another type of pneumonia that we might see, Legionella pneumonia. So these are aerobic gram-negative bacilli found in aquatic environments, reservoirs, cooling towers, humidifiers. So usually patients have some chronic underlying disease, COPD, renal failure, steroid treatment, and this can result in a very severe pneumonia. And the appearance is really, there's nothing specific about the appearance that would make you say radiologically that it's a Legionella pneumonia, but they develop consolidations that can spread rapidly and often bilateral. And patients can also develop pleural effusion. So it can give you a multifocal pneumonia, Legionella. Initially, you might have peripheral consolidations. It spreads rapidly, and 2/3 can develop effusions, although usually small, so it can give you a very diffuse pneumonia, Legionella. Here's some more examples. Consolidations here from Legionella pneumonia. May take a long time to clear, can lag behind the clinical improvement, may even appear to progress in a few days after treatment, although the patient is clinically improving. Usually we don't see cavitation associated with Legionella pneumonia. What's abnormal in this chest radiograph?
Pleural effusion and right hyoidopathy.
Yeah, so there's right hilar lymphadenopathy here. What about the right paratracheal region?
Also mediastinal lymphadenopathy.
Yeah, so there's right paratracheal lymphadenopathy also. So if you're looking at a chest x-ray like this, what's your differential diagnosis?
TBs.
In terms of infection, certainly tuberculosis, right? What else? Well, what else?
Sarcoid.
Is this a good appearance for sarcoid? I'm glad you brought that up. Is this a good appearance for sarcoid? What goes against sarcoid here?
It's not bilateral mediastinal lymphadenopathy. It's only on the right for the most part.
For the most part, it's only on the right. What about this guy over here? What's this? Pleural effusion. Are pleural effusions associated with sarcoid? No. Yeah, so that kind of is not your typical appearance for sarcoid. Besides TB, what else is in your differential for this chest radiograph?
Cancer.
Cancer, yeah. What kind of cancer?
Squamous.
Why squamous cell?
It's more central. The small cell going to be more peripheral.
Well, it could be any cancer, really, any lung cancer. It could be small cell, I suppose, but any lung cancer can give you lymphadenopathy and pleural effusion. Also, extrathoracic primary causing metastases, right? So we can see that. Another tumor that's associated with lymphadenopathy is what? Lymphoma, right? So that would be also in the differential diagnosis. But in this case, we're dealing with tuberculosis. So we've seen an increasing incidence for these reasons, influx of people from endemic areas, and also because of immunosuppression, if patients are on medications for immunosuppression. These are the populations at increased risk, patients with underlying malignancy, underlying lung disease, immunosuppression, post-gastrectomy. Gastrectomy also, interestingly, increases the risk for TB. Of course, HIV/AIDS, diabetics, homeless, prisoners, elderly in nursing homes, immigrants from endemic areas, all of these people are at increased risk for tuberculosis. The different terms you have to be familiar with in terms of tuberculosis, these are all the terms that we want to be familiar with. What do these terms mean? First of all, the pathophysiology, after exposure to tuberculosis, 70%, nothing happens. 30% might develop a primary TB, an initial infection there. A small percentage of those can go on to develop progressive primary TB, but the vast majority of patients exposed to tuberculosis, nothing happens. They have containment of tuberculosis. And in these patients, there's continued containment for the rest of their lives, and the only evidence that we have that they've been exposed is a positive tuberculin test for TB. But in a small percentage of these patients, later on in life, they can develop reactivation of what was dormant disease. So this is what happens with tuberculosis. After the organism is inhaled, patients can develop a localized pneumonitis. The organism survives despite phagocytosis by macrophages, and that's why the mycobacteria can be carried to lymph nodes via lymphatics, and they also get into the bloodstream, which is why they can be carried all over the body. which is also why many years after exposure to tuberculosis, patients can't present with brain abscesses or abscesses in the spine or discitis and osteomyelitis. So it's spread to lymph nodes, kidneys, epiphyses of long bones, lungs, vertebral bodies, brain cortex, and the severity of disease is related to the strength of the immune response. If cell-mediated immunity is strong and competent, the original focus and disseminated disease is eradicated, and again, the only thing left is an enhanced memory for TB antigen. If it's less vigorous, if cell-mediated immunity is less vigorous, disseminated disease is walled off but still viable, so these patients are at risk for reactivation later on. And as we know from tuberculosis, the damage to tissue is due to hypersensitivity reaction to the TB antigen. It's not the organism itself that is directly causing damage to tissue. If after initial infection, cell-mediated immunity is impaired, patients can develop progressive primary TB. And if there's very little or no host response, then you get dissemination. You can have miliary TB, hematogenous dissemination of tuberculosis, which we can see in the lungs as miliary nodules. The traditional teaching for TB, they used to separate primary TB from reactivation. Primary TB was associated with consolidation of fusion lymphadenopathy. Reactivation TB, upper lobe fibrocavitary disease. So it was taught that patients who developed upper lobe fibrocavitary disease, these are patients who have reactivation, whereas patients presenting with lymphadenopathy, well, this is primary. Is that correct? So what determines the various patterns that we see now with tuberculosis?
Immune status of infection.
Yeah, so it's the immune status of the patient, not the time since infection. I've given you this article also that talks about this. So what's the difference? So definitions: primary TB, disease within 1 year of initial infection. Reactivation TB, activation of old previously latent infection, greater than 1 year since exposure. Now, how clinically can they tell the difference? Well, with DNA fingerprinting of TB strains. If we have genetically identical strains of TB in multiple individuals, then we have clusters, then we assume that that's primary infection. However, if the patient has a unique strain of tuberculosis, then we might assume that that is reactivation TB, and this is how they can, with this DNA fingerprinting, decide whether it's primary or reactivation, and then we can compare that to what happens with the radiographic appearance. So it turns out that the radiographic appearance does not depend on the time since infection, but on the immune status of the patient. So upper lobe cavitary disease is associated with an immunocompetent host, regardless of when the patient was infected. So it could be an initial infection and they can develop upper lobe cavitary disease. Lower zone disease, adenopathy, effusion, that's associated with immunocompromised host, again, regardless of when the patient received the infection. So there's no difference in the radiographic appearance between true primary TB and true reactivation TB. The patterns that we see reflect the host's immune status. So immunocompromised hosts more likely to present with lymphadenopathy, immunocompetent hosts more likely to have upper lobe fibrocavitary disease, again, regardless of when the infection occurred. So three predominant radiologic findings, which may occur in any combination for immunocompromised patients: consolidations, adenopathy, pleural effusion, any of those three, any combination of those three. And the thing about the consolidations is that, well, first of all, more common in older children and adults compared to children less than 3. In children, the opacities that we see might be due to atelectasis, because children have smaller airways and they develop lymphadenopathy. It's easier for the lymphadenopathy to obstruct the airways and for patients to develop atelectasis. The consolidations are chronic. They rarely cavitate and require weeks or months to clear. Again, we're dealing with the immunocompromised host. So even if the patient is on TB therapy, you'll see that you don't repeat x-rays every week. The x-rays are repeated months apart. And you'll see that there isn't much change actually within the x-ray from 1 month to the next month. So the consolidations do take a long time to clear. So Here's a patient, consolidation from tuberculosis, still there 1 month later, really doesn't look any different, even if the patient is receiving therapy. Okay. Lymphadenopathy, we can have enlarged hilar or mediastinal nodes, most commonly paratracheal, hilar, subcarinal. So here's the prior study, there's the right paratracheal line, nice and thin. Here's the current study, this patient has right paratracheal lymphadenopathy. So this patient did have tuberculosis here. The prevalence of adenopathy decreases with age, so it's more common to see it in the younger age groups as opposed to the older age groups, lymphadenopathy from tuberculosis. There is something that can be characteristic of lymphadenopathy that we see with TB. What is it?
Caseation.
What?
Caseation.
Can't hear you.
Caseation. Like liquefaction of the central
What
part.
about the appearance on the imaging?
It's going to be hyperdensity in the center.
So low attenuation with peripheral enhancement, right? So low attenuation with peripheral enhancement from tuberculosis, we can see that. Also, there's kind of a matting of lymph nodes. You can see that the fat planes might also be obscured. So that's a finding that might suggest tuberculosis if we see that. There is a particular tumor that can also look like this when it's metastatic. What tumor is that?
Carcinoma?
RCC?
No, not RCC.
Carcinoma?
What kind of carcinoma?
Mucus.
What?
Mucus.
No, not mucin. You see it in the head and neck, the neuro. You see it all the time.
Oh, squamous.
Squamous cell cancer, right. Remember, those metastatic nodes to the neck, right? It looks like they're necrotic with peripheral enhancement. It's very similar to what you see here, okay? So squamous cell cancer, metastatic squamous cell cancer can give you a similar appearance. Central low attenuation, enhancing rims, obliteration of perinodal fat. These are the characteristics of lymphadenopathy that we see with tuberculosis. What am I showing you here? There's a term that we use that can put together the findings that we have here. First, what are the findings that we have?
Calcified lymph node and
Yes, so we have calcified lymph nodes, and we have
calcified nodule.
yes, calcified granuloma.
Granuloma.
Put that together, we get a what? What do we call this?
Ranking complex.
Rankin complex, right. So the gone focus is the initial site of parenchymal involvement that can heal with scar or granuloma. Rankin complex is gone focus plus an enlarged or calcified lymph node. So if you have an abnormal lymph node and you have some abnormality in lung parenchyma, like a granuloma, calcified granuloma, you have a Rankin complex. Okay. Pleural effusion. We can also see this with TB, probably from hypersensitivity response to the tubercular protein, usually unilateral, can be bilateral, can occur on same site as parenchymal disease. Don't forget about tuberculosis in young patients who present with a pleural effusion. Oftentimes they will tap the fluid, nothing terribly exciting. They get on the tap, maybe some low-grade inflammation is what they might see when they look at the cells, but the cultures could still grow tuberculosis, right? So for pleural effusion, especially in young patients, include tuberculosis in your differential diagnosis. So this patient presented with a large pleural effusion here and nothing else really except large effusion, maybe some tiny bit of pleural thickening, but not much else. This was tuberculosis. So TB belongs in your differential for pleural effusion. Can be the only finding in 5% of adult cases, and the prevalence increases with age. Progressive primary TB. So individuals, the cell-mediated immunity may be inadequate to control the primary infection. They get chronic disease. So it results in chronic active tuberculosis within 1 year of the active infection, especially in younger patients, usually upper lobe cavitary disease. So we're all used to looking at that from tuberculosis. Upper lobe fibrocavitary disease, what is the differential diagnosis? Besides TB. So you should have, I think, 4 things that might be in your differential diagnosis for this. TB also, topic we'll cover later on in this lecture.
Hypersensitivity pneumonitis or
Well, no, hold on. Hypersensitivity pneumonitis doesn't give you fibrocavitary disease, right?
Silicosis?
Silicosis can give you fibrosis, right? But not so much fibrocavitary with cavitation. Atypical mycobacteria, right? We're going to talk about that. That can do it. We did cover an infection a little while ago that can look just like TB.
Aspergillus.
Yeah. So the chronic aspergillosis infection can also look just like tuberculosis. Okay. Then there are some cases of sarcoid also. Although sarcoid tends to be symmetric, whereas TB tends to be asymmetric. Risk of reactivation, greatest within the first 2 years after primary infection. These are, of course, factors that predispose to reactivation of tuberculosis. Nothing surprising there. Findings associated with TB. So upper lung consolidations, cavities, fibrosis, bronchiectasis, bronchogenic dissemination, tuberculoma, pleural disease, dystrophic calcification. So upper lobe, bronchiectasis, cavitary disease, of course, we're all familiar with this. Why the predominance in the upper lobes? The original teaching was increased oxygen tension, promotes the growth of TB. Now we think it's because of less efficient lymphatic drainage from the upper lobes. So the pumping action of the ventilation and the excursion of the ribs in the lower lungs acts as a lymphatic pump. So the antigens from tuberculosis are more effectively pumped out of the lower lungs, but they can build up in the upper lungs. So that's the thinking about why we get fibrocavitary disease more in an upper lung distribution. You can get a little bit of mileage out of that theory also, less efficient lymphatic drainage leading to disease in the upper lungs. So what are other diseases that we think about that have a predominance of upper lung findings? Well, what's pneumoconiosis? Sarcoid. Sarcoid, one of the theories for sarcoid is reaction to unknown antigen, right? So if the antigen is removed from the lower lungs but not from the upper lungs, you get upper lung disease. And of course, the pneumoconiosis associated with upper lung disease is silicosis. Again, less efficient removal of the particles from the upper lungs allows then the disease to predominate in the upper lungs. Chronic, patchy upper lung consolidations with cavitation, right? So we can see that, of course, with tuberculosis. We should all be familiar with that. Volume loss, retraction of hyla, chronic atelectasis in the upper lobes, dystrophic calcification, bronchiectasis. All of this we will see with tuberculosis. What's going on in this X-ray?
Like lower lobe.
What do we see?
Fibrotic changes.
Well, what are we gonna call this? Yes, there's volume loss in the upper lobe. What are we gonna call that?
Sepally.
Large bulla or large cavity. What else do we see?
Mediastinal shape to the right.
Yeah, because of volume loss, right? And what else do we see?
Like the lip items.
I can't hear you.
I don't know, like the lip long, like there's like
Well, what do we call these things? What are we gonna call these guys?
calcified granules.
No, those aren't calcified.
Nodules.
This is not calcified.
Particular.
Do they look more nodular or reticular?
Nodules.
Nodular. So these are nodules. What do we think is going on?
Metastatic miliary.
Well, you mentioned miliary. Is this miliary tuberculosis? Yes. Why not?
It's big.
Biliary, these smaller nodules.
These nodules are bigger. Right. So they're not quite small enough for miliary tuberculosis. So what do we think is going on in this case then? Somebody with lectures on tuberculosis, so we're dealing with tuberculosis, cavitary lesion, tuberculosis, scattered small nodules. What explains the nodules?
Could it be bronchogenic spread?
Exactly, it's bronchogenic dissemination of tuberculosis. The cavity, of course, goes along with that. That tells you that it has access to the airway, right? So this is bronchogenic dissemination of tuberculosis, and it's very easy when you have cavitary lesions to get the access to the airway then. So we have these ill-defined 5 to 6 millimeter so-called acinar nodules. And then the manifestation of that on CT is tree and bud, right? So these tree and bud opacities represent bronchogenic dissemination of infection. We can see it, of course, with
So,
tuberculosis.
acinar nodules and tree and bud nodules are synonymous, just different modalities.
Very similar, right. The acinar nodules represent the inflammation that we see, like when this kind of coalesces into a larger inflammatory mass. Here's another nice example. You have a cavitary lesion from tuberculosis, tree and bud nodules. So we have airway dissemination or bronchogenic dissemination of tuberculosis in this case. And another nice one with these tree and bud nodular opacities from tuberculosis. So remember that the tree and budding can confine itself sometimes, like you see here, right, to a secondary pulmonary lobule. And those secondary pulmonary lobules is what you see on the chest radiograph as the acinar nodules. What are these nodules called? In a patient with tuberculosis. So these larger nodules, yeah, these are called tuberculomas. Okay. So tumor-like foci of TB, anywhere from 0.5 to 4 centimeters, find balance between activity and repair because these can contain viable organisms, tuberculomas. They can calcify, like you see here. Pleural disease. Often we see pleural disease also associated with tuberculosis, this pleural thickening or scarring that we can see with TB. But many times what we see as this apical pleural thickening really represents fat. See the fat? When you get the scarring in the lung parenchyma, the loss of volume results in extrapleural fat coming down and filling the space. So when the extrapleural fat comes down and fills the space, we see that on the chest X-ray as this area of pleural thickening. But it's associated with volume loss. Right? The hilum will be elevated a little bit on that side with volume loss in the right upper lobe. What's the finding here?
Left side volume loss and pleural thickening.
There's something special about the pleura here. What is it?
Calcified.
It's calcified. Yeah, it's diffusely calcified. What do we call this?
Fibrothorax.
This is called fibrothorax, right? When you have extensive pleural scarring with calcification, that actually leads to constriction of the lung and loss of volume there. So that's a fibrothorax. Severe pleural thickening, pleural calcification, fibrothorax. Okay? So what's the finding here on the CT? Calcified what?
Pleura.
Yeah, you have calcified pleura, and this stuff in here, so calcified pleura here, this stuff in here is a loculated collection, right? So what could cause this? Chronic empyema. Very commonly from tuberculosis. This was a case of chronic empyema from TB. There were organisms, viable organisms there when they tapped the fluid. What else is in your differential for calcified pleural collection? What else can do that? What's that?
Asbestos.
What did you say?
Exposure.
Yes, not asbestosis, but asbestos-related pleural disease, right? This is disease in the pleural space. Asbestos exposure can do that. Is there anything else that might be in the differential?
Mesothelioma.
Mesothelioma gives you a mass, right? So, if you're worried about malignancy, then you might think, asbestos exposure, tumor, mesothelioma. But they usually have a larger pleural effusion, and you have more of a mass-like component. What if the patient had a history of a motor vehicle accident many years ago? Yeah, chronic hemothorax, organizing hemothorax can also give you an organizing pleural collection. Yeah.
About the asbestos exposure,
Yeah.
would you expect fluid collection or just pleural counts?
You get both. Pleural effusion is associated with asbestos-related pleural disease. It is a cause of pleural effusion. So, pleural disease, empyema, air fluid levels, of course, if you develop a bronchopleural fistula or alveolar pleural fistula. And if we see pleural effusion, and we're thinking about tuberculosis, of course, it could be chronic empyema from tuberculosis. So it can contain viable organisms. This was chronic empyema from tuberculosis. Miliary TB, tiny nodules, small scattered nodules, can occur with primary or reactivation, just depends on what's going on with the patient's immune status. Radiographs may be normal in 25 to 40% at initial presentation early in disease, and the lesions may not be visible until 3 to 6 weeks after hematogenous dissemination. So I used to think that, in patients who had miliary disease, that they would be terribly sick. That's not the case. You can have an outpatient who gets a chest X-ray for malaise or whatever, and you find these tiny nodules. Don't forget about miliary tuberculosis. Okay, so it can do that. So, of course, tiny nodules, and you might have other findings, consolidation, cavitation, calcified nodes, lymphadenopathy that might point you in the direction of tuberculosis. And if we look on CT, the distribution of these nodules would be random. Yeah, it's hematogenous dissemination. So that gives you a random distribution of lung nodules. Okay. We see this a lot, of course. Chest X-ray for positive PPD. What is your assessment of activity of disease? Well, first, is there a finding on the chest X-ray? Yeah, there's a calcified granuloma, right? So now, the term we always like to put in our reports, if X-ray is negative, we like to say in the report, we say what? What do we say?
No,
After that, if it's a case for PPD, we include something else.
radiographic evidence.
No radiographic evidence of active pulmonary tuberculosis. What this question is getting at is if this is the only X-ray you have, and there is a finding there that can be related to tuberculosis, technically you can't put no radiographic evidence of active tuberculosis in your report, because it is possible that the patient might still have active disease. Unlikely, but it is still possible if this is the only X-ray that you have. This is the only film that you're looking at, okay? So what I like to say is, no consolidations, no cavitary lesions, calcified granuloma, consistent with history of exposure to tuberculosis. Chances are it's not active disease, right? But technically, if this is the only X-ray you have, you can't really say that. So a normal X-ray has a high negative predictive value for active TB, except in patients who are HIV positive, they do have a 7 to 15% false negative rate. But a single screening chest X-ray with any abnormality that could be related to TB must be interpreted as indeterminate for activity of TB, although you kind of have to be careful the way you phrase that, okay? So if, however, you have prior studies, if a radiograph has remained stable for 6 months, that usually indicates an active disease, but can be interpreted or should be interpreted as radiographically stable. Some patients might still have positive cultures for TB, but if you have an X-ray that is 6 months or older prior and it is unchanged, we can say radiographically stable. Notice that even after successful treatment for tuberculosis, after therapy, patients can still be left with residual findings, residual fibrosis, residual reticular opacities after therapy for tuberculosis. So TB, the foci can remain inactive over an extensive period of time and can still contain viable organisms. Cavitation and miliary disease on chest X-ray indicates active disease. So if we see cavitation, right, think about active disease. So if you see this in an ER patient, what are you going to tell the ER?
Precautions, airborne.
Isolation, right, if we're thinking about tuberculosis, because cavitation means that there's active disease and also that the patient can transmit the disease to others. Okay? Thoracic complications, some of this stuff we've talked about already. Of course, when they get extensive destruction, they can develop cystic spaces from the tuberculosis and the fibrosis. There's a term we use for what we see here for this particular complication of TB. Autopneumonectomy, yeah. So complete destruction of a lung to the point where it's completely non-functional. That's autopneumonectomy. So we can see that with tuberculosis. Lung destruction, you see that this lung is really not functional anymore. That is autopneumonectomy. What complication of TB does this patient have?
Tuberculosis.
What?
It has tuberculosis.
So this is an aspergilloma. It's a fungus ball that can grow in the cavity, right? So pre-existing cavities can give rise to fungus balls, so they can grow in cavities from tuberculosis. That's an aspergilloma. Okay? Rarely, any disease that gives you fibrosis can also increase the risk for cancer. So TB also, these patients also have a small increased risk for developing lung cancer as a result of the fibrosis in the lungs, bronchogenic carcinoma. Other complications, airways, bronchiectasis, stenosis. Bronchiectasis, of course, from the fibrosis that occurs in the lungs, that can happen. Here's a nice example, elevated right hilum, and we see that there's volume loss in the right upper lobe, and you can see the bronchiectasis in the right upper lobe from the scarring that's occurred on that side. See, the hilum is elevated here, chronic volume loss, chronic atelectasis in the right upper lobe, intraction bronchiectasis. Stenosis of the airways, that can also occur from scarring from tuberculosis, so that can occur. What complication of TB is illustrated here? Nice arrows to help you also.
Broncholit.
Yeah.
Calcified nodes.
Yeah, so what happens here is the calcified nodes erode into the airway and can result in atelectasis. So that's called broncholithiasis. So the calcified lymph nodes erode into the airway, obstruct the airway, and you develop atelectasis. Hemoptysis, atelectasis, post-obstructive broncholithiasis. What complication of TB is illustrated here? Yeah, so that's a vascular mass. Yeah, so this is a large pulmonary artery aneurysm. It's a Rasmussen aneurysm. So this can also occur from tuberculosis. So vascular lesions can occur from tuberculosis. Rasmussen aneurysm, pulmonary artery aneurysm can occur in the wall of a tuberculous cavity. Of course, hemoptysis would be the complication of that. Any chronic inflammation can lead to bronchial artery dilatation. And remember, the bronchial arteries are under systemic pressure, which means if they bleed, they can bleed a lot. So patients with tuberculosis can develop massive hemoptysis from bronchial artery dilatations. Okay? Here's an example. So these are dilated bronchial arteries from the chronic inflammation from tuberculosis. And you can see this dilated tortuous arteries. These are very friable. They bleed very easily. They're under systemic pressure. So the treatment for this would be embolization. Right. Rasmussen aneurysms, these aneurysms of pulmonary arteries, these patients would also be at increased risk for hemoptysis. And there are some mediastinal lesions that we can also see associated with tuberculosis. Lymphadenopathy, low attenuation here. When it heals, it can heal with some calcification. Fistulas from the esophagus. So esophageal mediastinal fistulas can also occur as the nodes, these necrotic nodes, can erode into the esophagus. So patients can develop fistulas between the esophagus and these lymph nodes in the mediastinum. So here's an example of that. So there's this mediastinal lymphadenopathy here, right, within the mediastinum. And this patient, it's quite subtle. This is actually after contrast, after we gave the patient oral contrast to drink. And you can see there's just this tiny bit of oral contrast that's here outside of the esophagus, and it's gotten into the mediastinum. So that's because of fistulas that can form from the esophagus to these mediastinal nodes. Fibrosing mediastinitis, more common with what infection as opposed to TB? Histoplasmosis, right, but can occur from tuberculosis also. What complication of TB is illustrated here? Pericardial calcification, which can lead to,
Restrictive.
What do we call it?
Restrictive.
Not restrictive, no. Constrictive pericarditis, right. So this can lead to constrictive pericarditis, okay, from tuberculosis. Pleural lesions, we can get these also as complications from tuberculosis. So we talked about chronic empyema, pleural calcifications, pleural effusions. That can be a chronic empyema from tuberculosis. Fibrothorax, pleural calcification that results in scarring and volume loss. That can occur from tuberculosis. What complication is illustrated here? Bronchopleural fistula, yeah. So you have these air fluid levels, these collections in the pleural space. So it's fistula formation, could be bronchopleural or probably more likely alveolar pleural fistulas. So communication between the alveolar space and the pleura. Many times we don't actually see the communication, it can seal off spontaneously, but the patient has a large air fluid level in the pleural space. So bronchopleural fistula or alveolar pleural fistula. In this case, you can actually see it. You see that communication there. So really, this is more of an alveolar pleural fistula than bronchopleural fistula. Chyloform, pseudochylous pleural effusion. This is kind of interesting. So as a result of chronic empyema, the white cells die and the fat accumulates, and you can get this fat fluid level within the chronic empyema, or milk of calcium. So that is called, because it resembles chyle, it's a pseudochylous pleural effusion. So it's not really lymphatic fluid, although it's milky like lymphatic fluid. So that's called a pseudochylous or chyloform pleural effusion. And so the milk of calcium can layer out if we turn the patient prone here. Well, you're trapped. There's no escape from chest pain. Chest pain radiating to the back. I will show you the current study, the study 4 years prior, what looks different.
What's disease?
What?
What's disease?
What's different on the x-ray?
I don't see anything.
Well, you have to be able to tell us what's the finding on the x-ray,
It should
right?
be like the vertebral body should be destructed. Like,
Do you see that? What do you see on the x-ray? Tell me what you see on the x-ray.
so there's retrocardiac, like,
Is there, when you compare this x-ray to that x-ray, what looks different?
There's deviation of the left paravertebral line.
Okay, so here, right, there's deviation of the left paravertebral line, right? What is this guy over here?
heart border.
That's the right heart border, right? What is this guy over here?
Is the right heart
Is that the right heart border?
Right paravertebral.
What is this guy then?
This is the right heart border.
That's the right heart border. So this is extending below the diaphragm. That's not the right heart border. So what is this?
It's right vertebral.
So the finding on the chest radiograph is what? The new finding is
Deviation
bulging of the paravertebral lines bilaterally, right? Which puts the pathology in what compartment? In the posterior mediastinum. Now, if I tell you the history of back pain in terms of posterior mediastinal masses that might be associated with back pain, you might consider, in a lecture on TB, we would consider then paraspinal abscess with discitis and osteomyelitis, right? That would cause bulging of the paraspinal lines. And so that's what we have. We have discitis, osteomyelitis, and this is a paraspinal abscess. That's what gives you the posterior mediastinal mass. Okay? And here's the reformatted view showing you discitis, paraspinal abscess. Okay? What complication of TB is illustrated here?
Empyema necessitans.
Yes, so this is empyema that breaks through the chest wall. That's called empyema necessitans. So these are all the thoracic complications that might involve the chest wall associated with tuberculosis. Empyema necessitans, if empyema breaks through the chest wall. That can occur with any empyema, but especially with tuberculosis. We already talked about paraspinal abscess from discitis and osteomyelitis. In this case, it could spread actually from the empyema to there. So the last part of this lecture, let's talk about atypical mycobacterial infection. So what's important to know here? No human-to-human transmission. The organisms are found in the environment. These are the organisms. These two are hard to separate, so that's why we call it MAI or MAC complex, okay? So non-tuberculous Mycobacterium fortuitum, this grows a little bit faster, and we'll talk about what's special about that one too. Criteria for diagnosis: cavitation or progressive disease on chest x-ray and at least 2 positive sputum cultures or evidence of mycobacterial on lung biopsy or positive BAL culture. There are different patterns that are associated with atypical mycobacterial infection, so you have to know what the different patterns are called. What is this pattern called? This is classic disease, so how do you recognize it?
TB.
Looks like TB, right? Upper lobe fibrocavitary disease. Although it tends to be more chronic, takes longer, does not progress as rapidly. So if it looks like TB, but the cultures keep coming back negative, or they can't, figure out what it is, it could be atypical mycobacteria. Looks like TB, fibrocavitary disease, tree and bud nodules, all of this, exactly what you would expect to see with tuberculosis. So it was the first type described, that's why it's called classic, M. kansasi in MAC. Most patients are immunocompetent, and insidious cough, hemoptysis, weight loss, predominantly males, especially males with COPD. Interstitial lung disease also can predispose these patients to atypical mycobacterial infection and smoking. Okay? So upper lobe disease, very similar to tuberculosis. So this also belongs in your differential. If the chest x-ray looks like TB, you could say atypical mycobacterial infection, classical disease. You can also get bronchogenic spread. You can also get adenopathy, pleural effusion, although that is much less common. And it tends to progress slower than tuberculosis, so it can be more chronic in terms of the appearance, comparing x-rays. So cavities, bronchiectasis, pleural thickening, M. kansasi usually responds, MAC characteristically resistant, and recurrence of disease is. If I tell you this patient has a chronic cough, what are the findings on the chest radiograph? Yeah, so it looks like there's opacity here. Could be in the right middle lobe. Looks like it's in the right middle lobe, right over the heart border there. Lungs here a little bit hyperinflated in this particular patient, okay? And the CT looks like this. What do we see on the CT?
There's a bronchiectasis.
Yeah, especially where?
Upper lobes.
Well, where does this lobe?
Right middle lobe.
Yeah. So if we have disease with bronchiectasis, especially if it involves the right middle lobe and lingula, what do we think?
Lady Windermere syndrome?
Yeah, Lady Windermere syndrome. Okay. So, and that is called non-classical disease, right? So this occurs in elderly females, so-called Lady Windermere syndrome, no predisposing lung disease, chronic cough, hemoptysis. What we look for is that distribution of bronchiectasis and disease in the right middle lobe and lingula, right? So opacities in the right middle lobe and lingula associated with bronchiectasis, elderly females, Lady Windermere, non-classical disease, atypical mycobacterial infection. So right middle lobe, lingula disease, especially with bronchiectasis, tree and bud nodules, non-classical disease. Multiple nodules or nodules. The differential, of course, is metastatic disease. So atypical mycobacterial infection can also give you nodules. And these are notorious for giving you a false positive PET CT. So everybody thinks it's cancer, they take it out, and it turns out to be atypical mycobacterial infection. So nodules, another manifestation of atypical mycobacterial infection. Asymptomatic nodules. Can be multiple.
A couple of previous slides, that chest x-ray could also look like bronchopneumonia, scattered. This one right here.
This one?
Yeah, there's some suggestive
Yeah.
cavitation.
I suppose on the x-ray you can't be sure, but on the CT, we don't have air bronchograms in there, right? These look more like solid nodules, okay? So nodules we talked about, asymptomatic nodules, of course we can see that also with MAI. Differentiating from neoplasm, not always easy. Lung cancer tends to have more of a dominant mass. and the nodules might look a little bit more inflammatory with atypical mycobacterial disease. What atypical mycobacterial infection is associated with the finding that we have here? What's the finding that we have here?
Achalasia.
How do you know?
Looks like there's a opacity posterior to the trachea.
You're right.
Follows the
This is
contour of the
opacity
esophagus.
posterior to the trachea. That's where the esophagus lives, right? And then you have this density here, right? What am I pointing to here? This is the right heart border. There's this opacity that's coming down below the diaphragm, lateral to the heart border. That represents what then?
Esophageal line.
Yeah, because of the dilated esophagus. That is the dilated esophagus. And of course, the beautiful finding that is illustrated here is one other very nice finding, that air fluid level, right? You have this air fluid level in the esophagus. So it's a patient with achalasia, right? So what infection is associated with that? Told you we'd get back to it. Yeah, mycobacterium fortuitum, or the rapid growers. These can grow within the esophagus with achalasia. And patients aspirate because of the achalasia, so it gets in the lungs, right? So achalasia, mycobacterium fortuitum. So these grow more rapidly, they're easier to culture. So they grow within the esophagus, then the patient aspirates, then they get into the lungs, right? So achalasia-associated infection. Patients who are HIV positive can also very commonly develop, depending on their CD4 count, infection with MAI, and that will manifest as what? Lymphadenopathy, right. So you have right paratracheal lymphadenopathy here, some opacity over the right hilum, lymphadenopathy. It can also be in the abdomen. We also see some enlarged lymph nodes here within the abdomen, so not only within the chest. But if they have a low CD4 count, patients who are HIV positive can develop systemic infection with MAI, which predominantly might present as lymphadenopathy, not much in the way of lung pathology, no lung damage, just lymphadenopathy. Okay? So disseminated disease in AIDS will present as lymphadenopathy, usually no pulmonary symptoms. And these patients will have positive cultures, positive blood cultures. So disseminated infection in patients with AIDS will manifest as lymphadenopathy. Sometimes they will also develop low attenuation lymph nodes, just like we see with tuberculosis. So patients with AIDS can also develop this with atypical mycobacterial infection. Okay. Patient is short of breath. The finding on the CT is what? Is that miliary?
Tree and blood.
You see tree and bud? Central lobular what? Ground glass. Yeah, this is ground glass attenuation, right? We don't really see well-defined nodules here. We see ground glass opacities. Of course, that's going to have a central lobular distribution. So also maybe a little mosaic attenuation from air trapping. So that combination then of central lobular ground glass opacities and some air trapping, what disease is that going to suggest? What? Hypersensitivity pneumonitis. How do we put that together with atypical mycobacterial infection? Hot tub lung. Right. So it grows within the hot tubs. This is called hot tub lung. So the atypical mycobacteria grows in the hot tubs. The patients inhale it and they develop this hypersensitivity reaction that essentially, is very similar to hypersensitivity pneumonitis. Hot tub lung. Inhaled MAC, and they develop this same pattern, central lobular ground glass nodules, air trapping. So essentially it's hypersensitivity pneumonitis as a reaction to the inhaled organism. Yeah.
This isn't the only cause of hypersensitivity, right? It's just one of
No. This is just one cause.
Just one.
Yeah. And pathologically, there's a little bit of a difference between this and hypersensitive pneumonitis, but as far as the radiology, it looks the same.
Okay.
But remember, bird fancier's lung, right? Farmer's lung, right? That's hypersensitive pneumonitis also, but that's not from this, right? So It's usually organic antigen that causes hypersensitivity pneumonitis. Right? So, classic infection gives you what pattern? What does it look like? TB, upper lobe fiber cavity disease. Non-classical disease? Lady Windermere syndrome, right middle lobe lingular, bronchiectasis. Of course, you can get nodules. Disseminated infection with AIDS will manifest as lymphadenopathy. Achalasia-associated infection, what is that? Mycobacterium fortuitum. And hypersensitivity pneumonitis is hot tub lung. Okay? All right, so quiz next time.